Hello, my name is Dr. Jean Connors. I'm a hematologist at Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. I'm the medical director of anticoagulation management and stewardship services regarding anticoagulation at Brigham and Women's and Dana-Farber. I'm an associate professor of medicine at Harvard Medical School. Today, I'm going to discuss coagulopathy in the era of COVID-19. These are my conflicts of interest. So my agenda for the next 30 minutes are going to cover three broad topics. What is coronavirus? Although now I think we know a lot more about coronavirus than we did even 3 months ago when I first started talking about coagulation abnormalities with COVID-19. I'm going to discuss what happens with infection with an eye towards coagulation and why thrombosis seems to be a big factor. And then I'm going to briefly discuss what, if anything, we should do about the coagulopathy that we are seeing. I'm not going to touch on specific antiviral or anti-cytokine treatments. So SARS-CoV-2 is a new coronavirus that's been discovered in the last 6 to 7 months that's similar to SARS and MERS viruses, SARS standing for Severe Acute Respiratory Syndrome. The infection with SARS-CoV-2 is termed COVID-19, standing for Coronavirus Disease 2019 by the World Health Organization. Infection with SARS-CoV-2 originates in a zoonotic reservoir, with bats and birds believed to be the reservoirs for all SARS viruses, and particularly bats for SARS-CoV-2. There's animal to human spread, so from bats to an intermediate animal, which with SARS-CoV-2 has not yet been identified, and then to humans. The virus itself is a positive sense single-strand RNA that requires the intracellular machinery to replicate in its host. And it has these surface spike or S proteins, these orange protrusions on the surface of the virus capsid. And this is what allows entry into cells because this S protein binds to the ACE2 receptors, the angiotensin-converting enzyme 2 receptors, which are present in the lungs, the GI tract, and the kidney. Interestingly, cleavage of the S protein is required for cell entry, and there are some in vivo data that suggest heparin can interfere with this cleavage process. Now, the reason that coronavirus has evolved into a pandemic that's infected over 6 million people globally is that no one has prior immunity to this virus. The R naught, or the ability of one person to infect other people, is approximately 2 to 2.5, meaning one person will infect 2 to 3 people that they come in contact with. While this is on the low side, say compared to measles, the fact that no one has prior immunity and that it's easily spread makes it particularly virulent. For all the data that I'm showing today, we really do not have true values for the severity, mortality, or any of the other event rates that I'll be discussing, as we don't have a handle on the true denominators for reported events. So this cartoon is one that's been used and was adapted by my colleagues at the Brigham for patients who have heart transplant. But I show this because there are clearly 3 stages to viral infection. There's the early stage where patients are infected and may have mild constitutional symptoms such as fever and dry cough. There's the second phase where now the host inflammatory response is starting to kick in, and patients may experience shortness of breath. This host inflammatory response is what causes differences in degree of severity of COVID-19 infection from patient to patient, with some patients developing a severe exuberant inflammatory response, and some patients unable to clear the virus rapidly. So the combination of viral infection and overwhelming inflammatory response can lead to ARDS and viral sepsis and shock. Now, before I get started on discussing coagulation abnormalities, I want to make sure that everybody understands what the D-dimer is, because D-dimer coagulation test has been used in a variety of different studies and has been shown to track the severity of illness and with mortality. It should be noted that the D-dimer assay is not standardized, so you will see people reporting different values with regard to units. Although they are all similar, they may be reporting nanograms per mil, micrograms per liter, but also the threshold value for range of normal varies, and you need to look at the D-dimer assay, particularly at your institution, to determine what is abnormal versus a normal value. D-dimer is produced when plasmin cleaves cross-linked fibrin. So you cannot get a D-dimer unless you have active coagulation going on. And the fibrin monomers are cross-linked by factor 13. And then with fibrinolysis and activation of plasmin, you get these fibrin monomers that were cross-linked with D domains, resulting in a D-dimer or two D domains in a fragment. The D-dimer can be elevated in many other situations besides COVID-19. It really lacks specificity. And if you look at this nice bar plot from investigators in Italy a number of years ago, looking at over 1,600 patients who presented to the emergency room in whom a D-dimer was tested, you can see that if you look at the very far right side, that patients who were ultimately diagnosed with VTE had increases in D-dimer levels and particularly met the threshold for greater than 3,000 nanograms per mil, but had levels less than 1,000 and in other quartiles or ranges of D-dimer in increasing succession. But when you look at this other vast array of diagnoses that patients ultimately ended up with that did not include VTE, you can see on the far left that patients with infection still can have elevated D-dimer levels, even to the height that we would see in somebody with a venous thromboembolism, simply because of infection. So inflammation overall can result in levels that are greater than 1,000 nanograms per mil. Now, coronavirus has sparked inflammatory reactions in many patients. And again, because people have no prior immunity to this can be a very robust response. Cytokine levels are elevated in all patients. The most frequently checked cytokine level is IL-6. The SED rate and CRP are elevated. One study looked at a wide variety of pro-inflammatory cytokines and found all of these were elevated and higher in patients who required ICU care. And if you look at this study, this graph on the right-hand side, and we look at troponin and myoglobin, but C-reactive protein and IL-6 levels, and we look at patients in the orange who died and did not survive compared to patients who survived the COVID-19 infection and were discharged, you can see that both C-reactive protein and IL-6 levels are significantly higher with a significant p-value in patients who did not survive and had more severe infection. Another similar study out of Wuhan looked at a number of biomarkers in patients who were admitted to the hospital and divided these patients into groups of survivors in the blue curves in these graphs versus non-survivors in the red curves. And of the 54 patients out of these 191 patients who did not survive, all of the patients had a sepsis definition. They met the criteria for sepsis with hypotension, refractory to fluid resuscitation, and other similar variables. Half of those patients had a secondary infection, either with bacterial organisms or fungus. And you can see when you look at these individual biomarkers that patients who had D-dimer levels that started to elevate days after illness onset the elevation in D-dimer tracked with mortality, whereas those who survived did not have this dramatic elevation in D-dimer. And similarly, IL-6 levels, although elevated in everybody who presented with infection, were higher in those that ultimately did not survive and continued to rise during hospitalization, such that the odds ratio for death with an elevated D-dimer at admission was 18, which is high, although the confidence interval is quite wide. Similarly, in another paper published in early February in JAMA, you can see that, again, survivors are in blue and non-survivors are in orange, that days after disease onset, you start to see this elevation in D-dimer associated with mortality that is not seen in patients who survive. Creatinine renal function also declines and starts declining rapidly after about 9 days of infection in patients who do not survive. Neutrophil count was noted to be elevated in this study. However, many of these patients received high-dose steroids at the time. And in this study, looking at specific coagulation test markers, you can see that patients have abnormal values at the time of admission. And so in this cohort of 183 patients, 162 survived, 21 did not survive. Again, the blue lines are patients who survived compared to those that did not survive. When we look at patients who were admitted and we look at their fibrinogen levels, we can see that these are elevated above the normal range. The gray line is the lower limit of patients come in with similar elevations in fibrinogen, but there is a change over time in those who do not survive, and they actually drop. And this may be associated with DIC, disseminated intravascular coagulation. But similarly, when we look at the D-dimer values, D-dimer values are already showing differential levels in those patients who do not survive, with higher levels in those patients compared to patients who ultimately survive. The PT is more elevated on admission and over the course of the ensuing hospitalization in those that do not survive compared to those patients who do survive, with minimal changes in the PTT. Again, these coagulation changes track with severity of disease, and are the more severe the coagulation test results, the higher the likelihood of death. One early paper that came out of Wuhan looked at 449 patients with severe COVID-19 meeting these criteria for severity of disease. And of these patients, 449, 99 were treated with heparin for at least 7 days. And now it should be noted that in China, the prevalence of VTE in the population is significantly lower than in Caucasian populations. So routine use of in-hospital VTE prophylaxis is not practiced there. But for some reason, there was a shift in severity, shift in care, such that 99 patients were somehow selected to be treated with heparin. This is not a randomized trial. We don't know what the criteria were for selecting the use of heparin, and the dose of heparin used in these patients were what we would use for prophylaxis here in the United States: enoxaparin 40 milligrams a day or 30 milligrams twice a day, or unfractionated heparin in a small number. When you compared mortality in these 99 patients compared to the rest of the cohort, there was no difference in overall mortality between those that got heparin and did not. However, if you then took patients in the non-treated cohort and compared with patients in the treated cohort, and you identified those who had the most severe infection or the most abnormal coagulation tests, in other words, if you stratified by SIC score, which is sepsis-induced coagulopathy score, or D-dimer level, you found that those that had a higher sepsis-induced coagulopathy score had lower mortality if they got heparin prophylaxis compared to those that did not receive prophylaxis, with a difference of 40% versus 64%. And similarly, if the D-dimer level was elevated above 3 milligrams per liter, these patients had a 20% reduction in mortality when treated with heparin compared to those that did not get treated with heparin. So this sparked a lot of interest in both coagulation testing and heparin use. And you can see on this bar graph from these investigators that if you had heparin treatment in the blue versus non-heparin, that the 28-day mortality was very different in those who met criteria of sepsis-induced coagulopathy, which included levels of platelet count, but also sequential organ failure assessment scoring that was elevated. And similarly, you can see that the higher the D dimer, the more the use of heparin seems to impact mortality. Again, we can't analyze these data for selection bias, and we don't know how patients were selected to receive heparin or not. And we must keep in mind when we're looking at this very high 28-day mortality over here, that these were 449 patients with very severe disease who were pulled out of a total number of over 1,700 patients who the rest of the cohort had mild or moderate SARS-CoV-2 infection. In a paper from Italy, we can see that the IL-6 level, interleukin-6 level, correlated with fibrinogen level in patients in the intensive care unit with ARDS, such that the higher the IL-6 level, the higher the fibrinogen level, clearly demonstrating the link between inflammation driving up levels of fibrinogen. Now, and to summarize a lot of data that came out, and some of which I just showed you, the data from Wuhan demonstrated coagulation test abnormalities. And initially, this was being called a COVID-19 associated coagulopathy. We see elevated D dimers, elevated fibrinogen, mild prolongation of the prothrombin time, rarely the partial thromboplastin time. Thrombocytopenia is very uncommon in these patients, and I did not show you any patient platelet data because it's uncommon. And DIC occurs much less frequently. And it occurs only in those patients who have prolonged hospitalization of 2 to 3 weeks in the ICU. They have sepsis, they have superinfection, and they may have other ICU-associated causes to develop DIC. The marked increase in D dimer is associated with severity of disease and mortality. And if patients do develop a DIC-like picture, this also correlates with severity of disease. However, this COVID-19 associated coagulopathy is not a coagulopathy as a hematologist interprets it. As I showed you, IL-6 levels correlate with fibrinogen levels. The sed rate and CRP are elevated. And so what we're really seeing is what we call thromboinflammation, where the inflammatory response and the pro-inflammatory cytokines are actually driving coagulation processes in a number of ways. And there is crosstalk between the inflammatory pathways and coagulation pathways in a number of ways that are listed here. We are seeing elevated levels of fibrinogen, factor VIII, and von Willebrand factor, and a variety of other activated components that can result in coagulation. Now, this cartoon from Blood in 2019 sort of demonstrates inflammation on one side and thrombosis on the other, and how they can meet in the middle to activate coagulation and cause thrombosis. And inflammation and results of inflammation can spark thrombosis, particularly in the microvascular circulation, which I will show you in greater detail. What we're seeing when there's inflammation is that the mononuclear cells that may undergo activation or even cell death in response to viral infection release neutrophil extracellular traps, and the components of the neutrophil extracellular traps can directly activate factor 12 of the intrinsic pathway. Polyphosphates that are a result of cellular damage can also activate the intrinsic pathway of coagulation. And platelets also get activated in this process. And so you can have intravascular thrombosis occurring in any size vessel, whether it's small or large. What also happens is that the natural antithrombotic function of endothelial cells gets disrupted. So this cartoon looks at the vascular endothelial cells, and all the components on the surface of these cells here are regulators of coagulation that inhibit the formation of thrombosis in patients. So we have nitric oxide, we have antithrombin, we have the protein C system, and activated protein C that inhibits the intrinsic and common pathway of coagulation. We have tissue factor pathway inhibitor over here that blocks factor 7A. So there are a variety of roles that the vascular endothelial cells play in preventing thrombosis on a daily basis. And what we see in microvascular thrombosis is that we have these inflammatory cells driving thrombin generation, resulting in fibrin meshwork and trapping platelets, but also platelet vessel wall interactions and the mononuclear cells, and they coalesce to cause microvascular thrombosis. And so these pathologic findings have actually been shown in autopsy specimens. So this is from Susanna Varga in Lancet, and you can see that in these renal electron microscopy sections that there are actually viral inclusion bodies in the renal parenchymal cells. In the small bowel and in the lung, we see these dark purple blobs that are mononuclear cell infiltrates, particularly in the alveolar lining and in the vascular lining, the alveolar capillaries in the lung. And when you stain with capsase 3, which is a marker for apoptosis, you can see heavy staining in the vascular endothelial cells, demonstrating that the endothelial cells and the mononuclear cells are undergoing programmed cell death or apoptosis, resulting in all those pathophysiologic processes that I just showed you in cartoons. This was also shown, this concept of endotheliolitis and endotheliopathy are also shown in another autopsy series, looking at first this section of the alveoli and looking at the interstitial and perivascular lymphocytic infiltrates. All these purple, blue, dark dots are not supposed to be here. And the thickness of these areas are much thicker than they would be without this inflammatory infiltrate. And we see multifocal endotheliolitis. We also see microthrombi in the alveolar capillaries. So these bright pink, if you will, areas are the alveolar capillaries that are responsible for gas exchange and allowing uptake of oxygen are all thrombosed in this specimen. In this same paper by Ackerman and colleagues, we can look at the microvascular, both pulmonary arteries and pulmonary veins have intravascular thrombosis and are completely obliterated, as you can see on this EM section in panel A. They stained the lymphocytes in yellow, and if you can appreciate all the lymphocytes that are in this specimen, those lymphocytes should not be there. But then when we look at hematoxylin eosin staining, we can see intravascular thrombosis in multiple different vessels. What was unique about this paper, though, however, is that they used CT imaging to reconstruct the bronchi in blue and the arterial pulmonary arteries in red. And in the panel on D, this is from a normal autopsy specimen, and this is from somebody with COVID-19 who died of COVID-19 infection. And you can see that there is ratty flow through the segmental and subsegmental branches. They're either completely obliterated or very narrow. And on these sections, you can see that that's due to intravascular thrombosis at a macro level compared to microvascular level. So these autopsy data correlate with microvascular and macrovascular thrombosis. And what we're seeing clinically also supports these findings. So when we look at a number of papers that came out in early April with regard to thrombotic events, these papers I'll discuss, but the worldwide cumulative incidence of VTE in ICU patients, despite prophylactic anticoagulation, is higher than historically. And so 2 papers from the Netherlands independently found that the cumulative incidence of VTE in patients in the ICU at 14 days was roughly 23 to 27%, despite the use of nadroparin, a low molecular weight heparin prophylaxis. In France, Julie Helm's group had been studying ARDS, and they took a current cohort of COVID-19 positive patients and assessed for thrombosis, symptomatic thrombosis, and compared to a recent historic cohort of non-COVID-19 positive patients, and found a difference of 11.7% VTE in the COVID positive versus 2.1% in the non-COVID patients. All of these patients were at least getting 4,000 units of enoxaparin or 40 milligrams of enoxaparin for prophylaxis. So despite prophylaxis, there was almost a 4 to 5-fold increase or 6-fold increase in thrombosis. And then Sophie Suzanne's group in France in this last paper looked only at pulmonary emboli in ICU patients with COVID-19, and they had other ICU cohorts that they compared them to. So 20.6% of their COVID-19 positive patients developed VTE, compared to 6% in a time-matched cohort, the exact time period in February, March 2019. But then they also pulled out all of their influenza patients, patients admitted with known influenza, and found that that rate was similarly low at 7.5%, markedly lower than the rate of pulmonary emboli that were being seen in the COVID-19 positive patients. Now, patients on the general ward did not have this elevated rate of VTE. The rates reported or cumulative incidence reported in patients on the wards is roughly 3%. Arterial events have caught the attention of the lay press, with young people presenting with stroke and distal arterial events requiring amputation. However, these occur much less frequently and are somewhere between 2 to 3%. So based on that data and based on our own internal data at Brigham and Women's Hospital, where we found that our patients in the ICU had a 4-fold higher incidence of VTE compared to patients on the ward, we changed our anticoagulation prophylaxis strategy. And so for patients who are admitted to the ward, they get the VTE prophylaxis. But if they're admitted to the ICU, we escalated to what we call intermediate dose VTE prophylaxis based on our data. Now, the ideal would be to have a randomized controlled trial proving that this increased dose is effective and safe. However, at the time, we had 7 ICUs going with 152 bed capacity. We had people pulled from surgery, from the ORs as anesthesiologists, for a wide variety of providers, all managing these patients, working extra shifts to care for these patients. And we needed to do something and make guidance policies that everybody could follow. And so we reserved therapeutic dose anticoagulation for those who had confirmed VTE only, or for those patients who were intubated, mechanically intubated, and unable to be moved, but had clinical findings suggestive of pulmonary embolus. We did not use a full dose or therapeutic dose anticoagulation in those who had ARDS, and we are currently evaluating our results. So in summary, COVID-19 causes multiple hits that result in thrombotic pathology. I like to say that this is Virchow's triad on steroids. We have a marked elevation in procoagulant proteins, which leads to the hypercoagulable state. We have the destructed and even destroyed antithrombotic protection that we usually see with vascular endothelial cells due to the endotheliolitis and apoptosis and just loss of those vascular endothelial cells that usually protect us from thrombosis. And then we have stasis in the small capillaries, simply due to the overwhelming inflammation and cellular debris that's present in the vessels, but also particularly in the ICU to patients who are paralyzed and mechanically ventilated. The ICU patients are at higher risk because they have more severe inflammation and more stasis. In addition to microvascular thrombosis, we're seeing macrovascular thrombosis with venous thrombosis, higher incidence than arterial, although both occur. And the microvascular thrombosis is not new in considering a diagnosis of ARDS, but it's the diffuseness and the total involvement of lungs throughout somebody when the degree of microvascular thrombosis that is really stunning in patients who are infected with COVID-19. Randomized controlled clinical trial data are desperately needed to determine appropriate dose of heparin in these patients that do not have documented thrombosis. We're involved with trials here at Brigham and Women's Hospital, and there are trials around the world. But all of the anticoagulation in the world that you give to your patient, if you give full therapeutic dose, it will not cure the patient of the virus. The patient needs to control the virus to recover, and they need to ratchet down their inflammatory response. So in addition to anticoagulation, patients need antiviral therapy, anti-inflammatory or anti-cytokine therapy. This question for macrovascular, venous, and arterial thrombosis is the standard dose of low molecular weight heparin prophylaxis sufficient? Should people be getting full dose anticoagulation? Randomized controlled clinical trials are up and running to address these questions. Other approaches have been tried, such as TPA, but there's anxiety about using TPA because it works while the patient has received it, but then they revert to their function after getting it, and how to safely deliver it is still not clear. And then there's this concept of thrombotic microangiopathy due to the endotheliolitis and the vascular disturbance. And are there ways that we can intervene, including these agents listed here below? Razaprotafib, which dampens down the activity of vascular endothelial cells and puts them in a more quiescent state. If the vascular endothelial cells has died, it's not clear how well this will work. Eculizumab, which prevents the membrane attack complex of complement forming, may prevent cell death. And then when these vascular endothelial cells die, they release high quantities of von Willebrand factor. And there's a suggestion that the von Willebrand factor concentration overwhelms the Adams TS13 concentration that's present. And we're seeing a thrombotic microangiopathy that might be similar to TTP, and whether or not there's a role for plasmapheresis or caplacizumab is currently actively being investigated. So I thank you for your attention. This is a slide that a colleague sent to me showing the sequence of events and the relative importance of a variety of aspects of daily life in the United States. Thank you for your attention.